Hi guys, in this part of this video we are going to highlight one of the most important parts of the vertical workflow. We are going to analyze the concept of the prosthetic space and how this concept is moved to the dental lab. So, we have seen that we have different kind of protocols. We have an edgeless protocol and the edge protocol. And we have seen that according to the drilling protocol, we have different kind of prosthetic space. For prosthetic space, I mean the space available for our technician for the manufacturing of our crowns. So, according to our drilling protocol, we can have more space or less space. Of course, we have advantages and disadvantages having one of these options. I mean, if we have more space, like it happens in many cases when we work with edgeless preparations, we have an easier lab work because the lab has more work for everything, okay? For the frame, for ceramic, even for the thickness of material in order that it is stiffer, stronger, okay? To obtain an easier aesthetic and a good aesthetic is easier, okay? Because of course the technician has more space. We all know that all the technicians in the world always ask for space. They have more freedom in the material choice because when you have space, you have room for everything. So for the technician, this is an old battle. Technicians always ask for space because they see things just from their own perspective. They ask for space, but they don't know the price that our patient, our teeth are going to pay. The problem is risk of sensitivity, cold for example. The problem is the risk of doing endodontic treatment. The problem is the huge biomechanical compromission because for giving all the space we need to do a huge tooth reduction, okay? And also the problems that we have seen on soft tissues when we do edgeless vertical preparation. Instead, we as dentists, we are much more concerned sometimes also on the other face of the moon. Because when we do the other kind of preparation, the minimally invasive protocol, okay, the lab work is tough because they have to work in a reduced space. To obtain a good aesthetic is challenging. You have less freedom in material choice. We will see that when you work in a minimally invasive way, the choice that you have are not so much. But you have a lot of advantages from a clinical point of view. The risk of sensitivity is completely reduced because when you keep the whole dentinal core and you keep also some enamel, the risk of sensitivity is almost zero. In many times you can do a lot of steps like removing provisional, trying frame-in without anesthesia, even on vital teeth of course. So the risk of doing endodontic treatment on this kind of abutments, even over time, because we know that there is a high risk of endodontic treatment on teeth, vital teeth, prepared for crown even after years. And it's quite annoying to have to remove a bridge or to do a hole in a bridge with all the problems related after a while because of necrosis of a tooth under a bridge or something similar. And there is also another problem, another advantage, the biomechanical preservation. When you do this kind of preparation, a minimally invasive protocol, the final result of the complex crown and abutment is something so stiff and so strong that it's unbreakable, okay? Because you keep all the dentin and you put a iron enamel, you save, and you put something that it is still stiffer, okay? Like for example a zirconia crown, and zirconia is stiffer than the tooth, and so you end up with a very strong tooth, okay? So we have to understand exactly our clinical needs. For example, if you deal with a patient with a young patient, young woman, for example, with a nice smile line, and an old man with a low, very low smile line, they have completely different clinical needs, okay? Don't do always the same work always follow the same path. Assess your clinical needs and the needs, of course, of your patient. And also it's about the availability of the material that you can use. When we do the minimally invasive protocol, the thickness on the axial crown, the thickness of the crown, the axial walls is often less than 1 millimeter. Often we are at 0.7, 0.8, and in the cervical margin where the crown is finishing, we arrive to 0.3, 0.2 millimeters. So if you have to work in this kind of space, you have not so many choices. You can work just with monolithic zirconia crown or with any other kind of monolithic material like lithium disilicate. Okay, you can work also with lithium disilicate monolithic. It's not so important if you want to do this with a press technique or with a cut technique, even if I like more the press technique where you do the conventional waxing and after you press everything. However, the first choice is monolithic material. The second choice is conventionally layered, possibly partially layered ceramic over zirconia. Okay, in these cases what I was doing was to layer just the buccal wall or the occlusal surface, just the aesthetic part, and maybe keep just the zirconia core on the lingual or on the palatal. The last choice when you are working with the minimal invasive protocol is a PFM. With a PFM, because we have the metal, the opaque, and a bit of ceramic, you need some space, okay? So you cannot combine the minimally invasive protocol and so often the immediate impression with a PFM, okay? You can work in an amazing way with PFM, with vertical preparation, but not with the minimally invasive protocol, okay? When you want to work with PFM and you want to do aesthetic dentistry, you have to do a deeper preparation. So in most of the cases, this will be an edgeless preparation. This will be a delayed impression after around 3 weeks for the healing of the soft tissue. And at this point, you can do an amazing PFM having all the space that you want. This that you see is on the first premolar is a porcelain fused to metal, a PFM crown after 10 years of follow-up. Okay, look, the aesthetic, the stability on soft tissues that we have, but this tooth was prepared in an edgeless way, in the conventional way. So it's not about a technique, okay? It's about the clinical needs of that single special patients. We have the ability, the possibility with our protocol, moving from the edge to the edges protocol, to decide where we want something. If we want something more or if we want something less. But I want always to remind the biomechanical and biological price that we are going to pay. Because in many cases, we are going to pay this price after many years, but the price is a great one. Because remember, however, that when you work with a conventional protocol, this is what you get. You remove all the enamel and you remove a part also of the dentin. This is, for a central incisors, the typical preparation that we do with the conventional protocol. Okay, look with very attention this abutment, and now look again the same tooth on a different patient prepared with our minimally invasive protocol. Okay, look the difference. You see here we have, look the color of this abutment. The color of this abutment is the same color of the neighboring teeth, and it's because this tooth has still enamel at 360 degrees. So we are working in a completely different scenario. And the difference is a big one, because we have to remember that when you drill a tooth for a prosthetic work, you have no second choice. It's a bit like this crazy sport like parkour. You have no second choice. I mean, if you do a mistake, you will pay. Your patient will pay and you will experience complications. I want to show some failure of mine. Look here, for example, in this case I did 6 anterior restoration, and on this side you can see that I did 2 crowns with this sort of big shoulder. 2008, good preparations of course. 2019, 11 years later. When you do an important tooth reduction, you pay a price about the long-term outcome. And this is what you get in many cases after 10 years, 15 years. Look at this case. This case is emblematic. 11 years later, I had a horizontal fracture, and the horizontal fracture, if you see, is always located where there is, again, the vertical wall coming to the shoulder, always in this point, because it is in that point that we have the load of the occlusal forces, the load of all the bending forces that act on our teeth. Show you another one. Look here, 2006, I did 6 crowns. Look here, the shoulder that I was doing at the time, I have the photo of the cast. 14 years later, okay? Look again, especially the lateral, you see, you have the shoulder, when we have again the vertical wall, that is the point where we have the maximum of the bending forces on our abutments, and where after time, bend after bend after bend, fatigue is starting to accumulate, and we have the final fracture. 11 years, 14 years. Okay, it's a long time, but if you're dealing with a young patient, and however, doing that, you are putting at risk the future of that abutments. Okay, it's something that you have to know. So when you do a huge reduction, you have to know exactly what are you doing. Okay, so honestly, unless I have a very pressing aesthetic request from my patient, and even in that case I always try to find a compromise, I did my choice. I mean, this is what we do when we do something at risk, okay? But like these guys are doing, I don't want to break my knee on the hard road. They have a foam pit, and our foam pit, in my case, has to be the restoration. I mean, today, if I have to experience a failure, it's 1000 times better to experience the failure on the restoration than on the abutment, because I can do again the restoration, okay? But if I have a catastrophic failure on the abutment, I have no space for doing something different, okay? If you have a vertical fracture or a deep horizontal fracture, there is nothing that you can do in that cases. So I want to move the risk from the tooth to the restoration. This is the reason because I've stopped completely doing shoulders, doing horizontal preparation. I want to do another kind of example. These are helmets. You know, when you go with your motorbike, and this is okay. Helmets are something that nowadays they work a lot also on the aesthetic of the helmet. But I want to highlight this sentence: behind design and aesthetic, there is a world of technological innovation whose main purpose is your safety. So, the most important part when designing a helmet and the crown is a sort of aesthetic helmet for our teeth is the first point is safety. First point. The second point is design and aesthetic. And about helmets, duration over time is just the last important point that they are going to develop. They want that if you crash somewhere, it's much better that your helmet is something completely destroyed, but your head is not, than not the opposite. The same concept has been used nowadays, for example, for safety for cars, for example. If you see a crash of cars 50 years ago, after a crash, the car was quite good, we can say, but the driver was killed. Instead, now we have exactly the opposite. The car during the crash is a mess, but maybe the driver is still fine. This is the same concept. So even when I do my crowns, I want that the first prerequisite that I am following is safety. Okay, safety. Of course, to avoid being bothered by my patients, I will pay a lot of attention that the duration of my work is good enough. Okay, and how do we do this? Our challenges. So we are working with crown with thin axial walls. So we are working with crown with thin axial walls. What are our challenges? 3 questions. Are crowns with thin axial walls prone to fracture under occlusion load? This is something that we will see also with Pasquale, but I want to do a short recap about this topic. Are crowns with thin axial walls prone to fracture during cementation? And are there any aesthetic critical areas to manage? So we start to collect all the concepts that we have seen in this video course. We will see this part in a deeper and better way with Pasquale, but I just want to give you a fast concept or to remind you this fast concept. This is an interesting study about the influence of the preparation design and artificial aging on the fracture resistance of monolithic zirconia crowns. They are comparing 30 crowns with the shoeless approach, so vertical preparation, 30 crowns with a 0.4 mm chamfer, and 30 crowns with 0.8 mm chamfer, and they are charging these crowns. These crowns will experience artificial aging with thermocycling at 55 degrees and mechanical loading and low temperature degradation up to 137 degrees. So we have a 0.8, a 0.4 and a vertical crown. Which crown do you think that will perform better in this study under occlusion load? This is the result of this study. Okay, it's quite counterintuitive, but vertical crowns perform better than chamfer. We have at the first place, we have the vertical crowns. At the second, we have the chamfer preparation with 0.8 mm, and just at the third place, we have chamfer with 0.4. And this result is always the same, with vertical preparation performing better, both when they do the thermomechanical cycling and both when they do the low temperature degradation. In every clinical, in vitro situation, vertical preparation, vertical crowns outperform chamfer crowns with chamfer. Okay, you can see here the result, the numbers on the top of the screen. Vertical crowns outperform the other kind of crowns under occlusion load, despite having thin margins. This is quite counterintuitive. The authors explain the favorable result achieved with the shoeless preparation by the stress distribution pattern during loading. They assume that during increasing loading, the crown could slide down the axial walls of the shoeless die without being limited by the margin. It means that if this is the abutment, my crown has no friction in this area, okay, because they are moving along the same line. Instead, horizontal preparation like chamfer have a stop, and when you put an occlusal load, you have this kind of force pattern that's completely different. So it's about the stress distribution. We will see also with Pasquale that the most important factor in order to have enough resistance to fracture during occlusal load is to have enough thickness on the occlusal part of our preparation. This is the reason because we are going minimally invasive on the axial walls, but we are never doing a minimally invasive preparation on the top. On the top, we are always doing a reduction of 1.5 millimeter, okay? But this is not an important area from a biomechanical point of view. The biomechanical area most important are the axial wall. When you reduce the occlusal part, and moreover in that part we have a lot of enamel, it's not so important, okay? It's not so important for a biomechanical reason. Moreover, even if we are dealing with a thin crown, like a monolithic zirconia crown with axial walls less than 1 millimeter, we have always to remind that when we place a material in a tubular structure, the resistance, the mechanical behavior changes completely. Let's think to a plastic glass. When the plastic glass is broken, you can move this very easily. But when it's in a wall piece, you see that there is a completely different kind of resistance. Point number 2. This is a very important topic because on this step we have spent a lot of time to solve this problem, and we had a lot of problems because our crowns with thin axial walls prone to fracture during cementation. This is a big problem. And it's something, yes, the answer is yes, they are. And this is the reason because we have been forced to completely rethink all the lab protocol, okay? And this is the reason because we have seen in our slides that our drilling protocol is completed with the lab protocol. Because if you work with the conventional lab protocol with this kind of preparation, you will experience a lot of chipping and fracture on your vertical crowns. This is a problem related to the geometry of vertical preparation. This is a famous study of Gavelis. It was about the effect of various finish line preparations on the marginal seal and occlusal seat of full crown preparation. Here they were comparing different kind of various finish line. They were comparing feather edge preparation, 90 degrees shoulder, 45 degrees shoulder. They were comparing also this kind of preparation with bevel or without bevel. And for a geometrical reason, when you start to increase the angle of your preparation, the gap, the distance between the abutment and the crown starts to decrease more and more according to the angulation of these planes. I show you. Look at the image here on the top. You see that the D, the big one D, is the distance between the crown and the abutment, okay? But when, look at the image on your left, lower left, but when you start to move from this kind of preparation, you start to do something like this, you see that the second D, the small one, is less than the first D. It's a function, mathematical function of the first dimension. So when you work, I will do some slide about this, to visualize this point. So increasing the angle of the preparation for geometrical reason improves the marginal seal, okay, without cement at this point. I want to do some slide about this. This is a typical horizontal preparation. If for any reason we are not able to seat the crown on your abutment, the exact distance that we are not able to seat our crown is the same opening that we have in the area of the margin. Okay, look here. The same distance that you have on the top of the abutment, that it is the distance that you have not been able to seat the crown, is the same distance that you have in the lower part. Let's do the same here on a vertical preparation. I have moved the crown of the same distance. Look, the situation is completely different. If you see, the distance on the top of the abutment is always the same. I am not joking, guys. I am not joking. This is the reality. You can do this with Keynote at home. But look instead on vertical planes, which kind of opening we have at this time. Because of the geometry of this vertical preparation, the marginal opening is completely different. Look, here I have arrived almost to half of the abutment, and the opening that you have between the tooth abutment and the crown is even less than the first example with horizontal preparations. Just to give you again another example, look here what happens when we have a so-called both preparation in the same area, a shoulder and a vertical plane, like a beveled shoulder. Okay, look here, this is the first image with the crown perfectly seated on the abutment. Again, look the difference that we have. Here again, the distance that we have on the top of the abutment is the same that we have on the horizontal wall. But when we move to the vertical wall, look, the distance is 10 times less. I'm saying 10 times just to give you a number, but it is n number of times less. This is a completely different concept. The problem is that this game is very nice if we talk about the marginal seal of vertical preparation, that it is something that it's true for sure. Okay, with vertical preparation, we always have a better marginal seal. But when we put the cement in this equation, something changes, because cement has to escape somewhere. And with this kind of feature of vertical preparation, the room that the cement finds to escape is always less and less. And the hydraulic pressure that our cement will develop, it is a lot. And if you're working with metal, this is not a problem, unless that you have to put a lot of force. But if you work with thin monolithic zirconia crown, you can crack a lot of crowns. Because you see, with the horizontal preparation, when you put the crown, the cement has a lot of space to escape, because we have seen the marginal opening that we have. But with vertical preparation, you have not this ability, okay? The room, the space for the cement to go away is less, always less and less. And so, we have also to understand which kind of cement we are using. This is a slide about the minimum cement thickness. We see that glass ionomer cements are the cement with the minimum cement thickness, while composite cements are the cement with the biggest film thickness. What is the point? And this is are in ideal condition, okay? If you take your cement from the fridge, that is something that many do for storing material, dental materials, these numbers increase many times, okay? So what is the point? The point is that if you're using a cement whose, let's say, minimum film thickness is 50 microns, let's say, okay? But the space that we have between the tooth and the crown, because of our vertical preparation, is, let's say, 25 microns, there is a problem, because the cement is 50 micron, the space is 25 micron. How is possible for something bigger like this to go inside this one? It's impossible. So what happened? It happened that we have a lot of hydraulic pressure on the walls of the crown, and most of the cement will go on the top of the abutment, and you will not be able to sit correctly the crown on your abutment. And after this explanation, you will understand in a very clear way this study. This study is always the same study of Gavelis, and they were comparing the occlusal seat and the marginal seal. Okay, and what was the result? The result was that the marginal seal for vertical preparation that you see on the left of this slide was the best one. Okay, in this study there were something like 30 microns, but the occlusal seat was the worst. So feather edge preparation, vertical preparation, has the best marginal seal, but the worst occlusal seat due to limited escape for cement. And this is a problem that we need to address, because with vertical preparation, when we are going to cement our crowns, we have always, even when the material is tough, like metal ceramic crown, we have the problem of seating correctly the crown on the abutment. Okay, because in many times you will have the crowns that it is not completely seated because of this problem with the cement. And if you are working with thin crowns, we will experience also the problem of crack, because this cement, not being able to go away from the crown, will develop a huge hydraulic pressure on the axial walls of our restoration. These problems, the problems of the seating, was already present with metal ceramic crown and in the past. I perfectly remember that when I was delivering a bridge with multiple abutments, in order to make this bridge to arrive in the final position, and I am afraid that in many situations I was not able 100% of the case to do this, but it was something that you needed to apply a lot of force. I perfectly remind this, you was feeling the resistance. But when we started working with monolithic zirconia crowns, and when we started working with thin monolithic zirconia crowns, also the problem of crack and fractures started to arise. This is the typical situation that we have to face when we work with thin monolithic zirconia crowns and vertical preparation, the crack. And this problem is increased by the conventional lab protocol. In the lab, we will see this in more details in another video course. In the lab, they usually put a spacer. The spacer is a sort of varnish that helps to give some more space, because it has been shown in dental literature that the retention of the crowns and the seating of the crowns is enhanced by the presence of a varnish of this sort of die spacing. The point is that in many situations, in all the conventional protocol, this varnish, this die spacing, is placed from the top of the abutment, and there is no spacing instead on the cervical part. The problem is that putting the spacer in this way, the problem is that putting the spacer in this way, all the problems that you have seen before are even worse. Okay? You already have this sort of space, and at the end you have very limited space. And if you put this sort of spacing in this area that it is the critical one, the space is always the same, while you have more space on the top of the abutment. So it's much easier that your cement will move to the top of the abutment, and that you will experience problems to seat perfectly the crown. Okay, so this approach has not been the best with vertical preparation. This is something that works perfectly with horizontal preparation, this sort of approach, because they have an horizontal stop. Let's see this. So the problem is, because all the world is moving in an horizontal way, they have used, most of the people use the same concept of dental lab of horizontal preparation on vertical preparations. So this is what happens when you place the normal die spacing technique. In the red on this slide I put the spacer, and you have the situation removing the spacer. All the friction is enhanced, and it is on the third cervical of the crown, on the cervical third. So what happens using this approach? That you have a lot of stress on the cervical area of the crown, that in our approach, in many cases, is 0.2, 0.3 millimeters, okay? You have the biggest stress on the thinnest area. There is a reduced escaping for the cement, and you have a worsened seating of the crown. And the problem is that being our margin in this area 0.2, 0.3 millimeters, it's very easy to experience a crack and chipping, especially when you work with monolithic zirconia crown or lithium disilicate. Another problem, the small escape again. The small escape of cement make reduced seating of the crown, but with the geometry of the vertical finish line, the gap may be less than the minimum cement thickness. And so what we have seen doing the sections of some teeth with this kind of preparation is that there are a lot of places where there is no cement in this area. Okay, this is a very small space, but this space is not sealed by anything. I will show you this. Just to give you an example, in the conventional protocol, the protocol was to check if the crown was manufactured in a good way, was to put a material that was fit checker, that was to check the introduce of the crown, and the conventional protocol was asking that there was no fit checker on the cervical area. The average film thickness of fit checker is 20 micron, less than many cements. So if you see no fit checker or void of fit checker in some areas of this crown, for sure cement will not be able to go in. But removing some vertical crowns made with a conventional approach after a while, we have seen that there is the filling of this sort of places with some debris, with some dirty things. I will show you. This is the problem we are talking about. We have used here a colored cement, a red one. Look here. Maybe I have to move. Look here. You see, we have cement, the red one, but we have nothing. It's not cement, it's a void. There is a void on this point, okay? There is nothing in that area. And because that space, but there is a space sealed by anything. Because the cement is not able to flow in that area and find other places where to flow. So this is what I'm showing here is a very typical situation that you will have with vertical preparation. This is a crown on the vertical preparation made with a conventional approach, courtesy of a follower of our group, Cristi Dumitrescu. He did the crown, a very good crown, on these lateral incisors, and because of the color, the crown was removed after 12 months. Look here, this crown, and let's look at this crown now. You see? Look here, you have cement, but you have no cement on the margin, on the cervical area. But despite not having cement in this area, you start to see this sort of dirty, this sort of debris, you see? Because there is a small space, but it is not sealed by anything. This is another case that courtesy from Matt Costa. You see, there is cement, but there is no cement on the cervical area, on the cervical margin. And look in that point, that sort of debris, that sort of dirty that is starting to accumulate. This is because there is a huge difference in the approach, in the rationality between horizontal preparation and vertical preparation. I want to do now another kind of example. We know that when we work with our dental materials, we have sometimes an expansion, sometimes a shrinkage. With the plaster, usually we have a small expansion. Now I want to increase this sort of expansion to give you an idea of what is happening when working with vertical preparation in comparison to horizontal preparation. This is my horizontal preparation. I put my spacer in the conventional way and I do my model. Okay, here I simulated a bit of expansion of the abutment. So I do my crown in that way. And after I move my crown to the natural abutment. Because this crown has been made on a bigger abutment because of the expansion of the material, we see that when we go back to the abutment, the problem that we can face is that there is a small hovering, maybe, on the shoulder because the crown is bigger. Of course, I am increasing every kind of problem that we have. But because there is a cervical stop, the crown arrives always in the same position. But now let's do this in a preparation where we have not a cervical stop, okay? We do the same die spacing approach, the same kind of die spacing technique. We have a bit of expansion, we do our crown with conventional spacing protocol, and we go back to our situation. What happens? Because we have no cervical stop, the crown will have two kinds of problems. We can have an over-sitting on edge preparation. What means? Because there is no cervical stop on edge preparation, the cervical margin will move away in this way. Okay, will move in this way, and you will find the stop on the head of the abutment. But if you're working instead on edges preparation, like here, because the wall is longer, our margin will find again another sort of friction. And when you do this, you will have a cervical friction. So when you work with this kind of protocol, and you're working with the edges protocol, you will have many times friction on the cervical margin. And being again this area a very thin one, in a lot of situations you experience a small chipping. It's just about if you have the stop on the top of the abutment or on the cervical wall, where is the first point touching. But if you have the friction of the cervical part, if you just put with your finger, you will chip a monolithic zirconia crown. Again, oversitting and cervical friction. When you apply the same die spacing technique of horizontal preparation to vertical preparation, you will start to experience these sort of problems. And this is the reason because when we started to use very thin monolithic zirconia crown, we experienced a lot of chipping and fracture during train and a lot during cementation. And this is the reason because we have been forced to rethink the whole lab protocol, and we moved to another kind of approach that it is completely counterintuitive, but that works in an amazing way with vertical preparation, the Tomorrow Tooth reverse die spacing technique that we will see in the next video. For this video is everything. Bye guys.